Hello cruel world. Why is mental illness so prevalent in prison? How is it treated? What's it like working as a psychiatrist in prison? And what are prison guards like? I'll be answering all of those questions and many more in the next few episodes. My name is Dr. Sohom. I'm a consultant forensic psychiatrist. I assess mentally disordered offenders for a living so that you don't have to. Welcome to my series on mental health in prison. I'll be taking you through not one, not two, not three, not five, but 4 episodes. I'll be giving you real life case examples that I've personally assessed from my experience, and I'll also talk about high profile cases, including later on in this episode, the tragic suicide of Sarah Reed, who died in her cell in Holloway Prison on the 11th of January 2016. She was very young, she was only 31 years old. First of all, I'm going to explain my experience of working in prison and tell you about my different roles, because I've worked in 2 different contexts and the experience is very different. So firstly, I used to work regularly a couple of days per week in a huge female prison in Ashford in Middlesex. In fact, it was the largest female prison in Europe. And there I would run healthcare clinics, and I'd also oversee patients in the healthcare unit. Also on top of that, I've done hundreds of one-off medico-legal assessments, which is where I'm a visitor to many different prisons, mostly around London and the south of England. I have been as far north as Leicester, I think. So these are one-off reports for the court, and it's usually for prisoners who are on remand and it's during their criminal trial. So for example, I'll talk about things like fitness to plead, not guilty by reason of insanity. If you want to know a bit more about those psychiatric offences, you should check out my other videos. I've mentioned them several times in different cases. Just go and sift through my videos. So firstly, there was the prison clinics. So that's a bit like when you might visit a psychiatrist in the community. So in the prison where I worked, the prisoners would be given appointments and they were expected to turn up. And they went to a medical area which was away from the main wings of the prisons where their cells were. And they would knock on the door, they'd be let in by a receptionist, and they'd sit and wait in a waiting room. So just like seeing your general practitioner. And for most inmates, they were not escorted, so they were allowed to walk around, and it was their responsibility to turn up to their appointments. Obviously, there were certain areas of the prison that they were not allowed access to, like the administration offices. I'd say that very generally speaking, the patients that I saw in the prison clinics were not extremely unwell, because if they were that unwell, they'd be going to their healthcare units. So the kind of things that I'd be dealing with in the clinics would be changing doses of antidepressants. Sometimes if the prisoners were on antipsychotics, if they had low-level paranoia or psychosis, I'd see them for that. So I basically saw them in a small office that had a computer, same as a doctor's office in the community, but obviously everything's surrounded by locked gates. Occasionally I would see some unusual presentations like obsessive compulsive disorder. I would give medication for that. Sometimes I'd see post-traumatic stress disorder. So sadly, most of the female prisoners that I saw had a history of trauma, from domestic violence to being victims of sexual and physical abuse. So that was very common. I have to say, where we worked in my female prison, we had an exceptionally strong psychology team. So I would refer prisoners for individual or group therapy. I think it's only fair to say that some prisons are not like that, especially in the male estates. There's just not enough therapists to go around. And in these kind of places, unfortunately, only the very, very mentally unwell get treated. It is frustrating, but it's something that we just have to accept working in prison psychiatry. So in a previous episode on this channel, I've interviewed a man called Chris Atkins, who was a journalist who actually served several months in prison related to fraud. You should go check out that episode. He told me that it would be common that he would see many mentally unwell prisoners who would just be wandering around, talking to themselves, disorientated, disturbed. That gives you a kind of idea of what it was like. Just to give you an example of an unusual presentation that I would see, that would be gender dysphoria. So sometimes we would meet women inmates who wanted to transition from female to male. And generally we supported that. What we'd do is we'd refer them on to a specialist clinic which was based in Charing Cross in central London. And there was a 2-year wait just to be seen by the clinic, let alone to be assessed or treated. And my role in this kind of scenario would be to do a basic psychiatric assessment to make sure, for example, that their intent to change genders was not related to mental illness such as schizophrenia, because you can reverse delusions with antipsychotics, but it's much harder to reverse surgically grafted male genitalia. The other place that I've worked in, as I mentioned, was the healthcare unit. So my involvement here would be much more intense and possibly more interesting. And the healthcare unit is a bit like a psychiatric ward inside a prison. And there's usually around 12 spaces for the most unwell patients. Technically, the healthcare unit is also there for physical health issues, though when I worked there, I saw this extremely rarely. The healthcare unit I worked in, almost every single patient there was either psychotic or was there because of extreme self-harm. I think in my 2 years, I saw one patient that was in a wheelchair for a few months who had had a stroke, but that was the only time I saw a physical health issue. So that just shows how prevalent psychiatric illnesses are in prison compared to physical health problems. Usually the prisoners that are in the healthcare unit are so unwell that they need to be transferred to a psychiatric hospital. So it's like a secure unit that's got an extra level of security for offenders. The healthcare unit is also away from the main wings, and it's kind of separate. It's a lot quieter, it's a bit safer. Oddly, always smelt of detergent, never really understood why, but that's something that really struck me. And there's a large number of prison guards to inmates compared to the main prisons, and you also have doctors and nurses. So doctors like myself would visit once or twice a week. Nurses would be there every day. The other thing about the healthcare unit compared to the main wings is that the prisoners were locked in there for most of the day, and there were cameras in the cell. Generally, only one or two were allowed out in the communal areas at one time, just to make sure there was no problems. When you've got agitated, disturbed prisoners, obviously things can kick off. And there was like one quite nice lounge with a TV, and oddly lots of jigsaw puzzles, just hundreds of jigsaw puzzles, I'm not sure why. And there's also a box of games in the corner, although in the 2 years that I was there, I don't think I ever saw anybody open one single game. And obviously there's a much higher level of observation. One thing that I should say, a real challenge for me working as a prison psychiatrist was that it was a lot of time and effort to transfer people from the healthcare unit to the secure hospitals they needed to go to. And there were these huge waiting lists. And to be perfectly honest, I felt some resistance from some services, probably because they were overwhelmed and they didn't have spare beds. But sometimes I'd refer a really unwell patient and the services wouldn't reply for weeks. Sometimes I had to chase them up repeatedly, even though the defendant was extremely unwell. I've seen prisoners agitated, shouting, screaming, banging their heads on doors and walls. I've even seen prisoners smear feces all over the wall because they're that disturbed. Occasionally, there'd be prisoners that were refusing to eat. Some were so paranoid that they believed their food was poison, so they would only eat packaged food. Sometimes prisoners wouldn't shower. So personally, I'm ashamed to say this, but I found resistance from these units in accepting the prisoners for admission, for psychiatric admission. So I'll give you an example. Let's say a woman committed an offence in central London and previously had been detained in East London and now lived in West London. Say they had a GP practice that was registered in South London. Each one of these has a different NHS trust, different catchment area, and every time I'd refer to one place, they would knock me back. They would pass the buck onto another jurisdiction. And basically everybody seemed to want to wash their hands of the responsibility of accepting these prisoners. And it was very frustrating and it was very time consuming for me and my colleagues. It just felt like there was no kind of urgency from these services and they had very little respect for me, what I was trying to do, and my colleagues. And then sometimes when they finally agreed that the patient actually belongs to them, they would either not agree that the patient needs admission, even though to me it seemed that the prisoner was floridly psychotic. And ultimately it's their decision, it's not mine. I can't force it because those units belong to those particular psychiatrists. Or at times they would agree that the patient needs admission, but there'd be like an internal disagreement about the level of security. For example, low secure, medium secure. Does the prisoner need a special learning disability centre for offenders? So all these different psychiatrists and managers would have their different opinions. There'd be internal disagreement which would slow the process down. And even after all of that, when the patient has finally been accepted to a specific ward, sometimes we'd have to wait between 4 to 6 weeks for a bed to open up. because these wards are usually at capacity. So they have to discharge somebody till they can accept somebody else. And I should say that, to be fair, this didn't happen all the time. It wasn't every single referral, but it was enough that it would give me a headache every week. It's probably the most frustrating part of my job. Okay, so the next question is this: how rife is mental illness in prison? Well, over half of prisoners have poor mental health, including depression, anxiety, post-traumatic stress disorder, and around 2% of prisoners are thought to have acute and serious mental health problems. So what I mean by acute and serious is that they probably should be in hospital. The other thing I would say is that levels of self-harm in prisons have hit a new high. There's more than 60,000 incidents a year, which is mind-blowing. Another episode in this series, I'm going to talk about the case of Miss P, which is an extremely serious cut-in to the point that she needed plastic surgery. I'm going to tell you a bit about how we look after self-harming in prison, so look out for that episode. So the official figures show that the number of self-harm incidents have been growing exponentially since 2014. As I said before, 60,000 incidents between 2019 and 2020, and in part, in my opinion, this is related to overcrowding and also underfunding. So before I tell you about the tragic case of Sarah Reed and her suicide in prison, let me first introduce you formally to this channel. So welcome to A Psych for Sore Minds. It's hosted by me, Dr. Sohom Das. I'm a consultant forensic psychiatrist. I carry out assessments regularly in prisons and in courts and in specialist secure psychiatric units. I make videos on a whole range of topics, some of which are related to offending and violence, because that's my area of expertise, but also some general mental health topics, more kind of typical for and more common for the average person. What I'm trying to say is there's something for everybody on this channel. There are interviews with different patients, interviews with people who have experienced mental health issues, who've been sectioned. Just go check it out. Okay, so I'm going to tell you about the tragic case of Sarah Reed. She was a mixed race black woman, and she suffered serious mental illnesses since the death of her child in 2003. She suffered from bulimia, paranoid schizophrenia, and this was all on the background of serious alcohol and substance misuse problems. And Sarah had been in and out of psychiatric units for most of her adult life. In 2012, Sarah Reed was the victim of a severe attack from a white police officer called PC James Kiddie. So this constable apparently grabbed her hair, beat her around the head, and she suffered 2 broken ribs. And this all happened after the constable had arrested Sarah falsely for shoplifting. And he was found guilty of assault and he was sacked, and he was sentenced to a community order because of this exact incident in 2012. So Sarah Reed, she died in her cell on the 11th of January 2016. She was in prison, charged with grievous bodily harm with intent from an incident in 2014. She was initially on bail and then she was remanded in October 2015. Unexpectedly, she didn't know that she'd be remanded. And this all happened at HMP Holloway, which is a female prison in North London. It has since been shut. This wasn't an incident that caused it to be shut, but I think it certainly contributed because the inquiry did not spray it with praise, let's put it that way. I've personally done a few assessments in HMP Holloway before it shut down. So Sarah wrote to the jail insisting that she was acting in self-defense. And then a few days after her arrest, she suffered a sexual assault apparently while she was detained in the Maudsley Hospital. When she was under section, she was apparently sexually grabbed by an old white man in hospital. After she'd gone to prison, Sarah had been waiting for 9 weeks in prison for a fitness to plead assessment, but it never happened. So then after her death, there was an inquest and they found a series of failure in the prison. She was not treated in a timely manner, she was not assessed, some visits were cancelled by staff, she wasn't offered baths or showers appropriately, and the prison inspectorate did a report which was released in October 2016, which makes for grim reading. It criticised the prison's slow transfer of women with mental health issues to secure hospitals, which is exactly what I was just talking about, and it is pretty disturbing considering this happened in 2016 and my experiences were later than that. So I was in the female prison, I think end of 2016 to 2018. And I think part of the problem is that nobody's responsible for the medico-legal report. So prison psychiatrists are responsible for treating the patient in prison. Then the psychiatrists from the secure units are responsible for accepting the patient and treating them after they've been transferred. But there's not really anybody that's responsible for the medico-legal stuff in the middle. It is the responsibility of the solicitors, the defence solicitors, to sorted out. There's not really any kind of time restriction. So it should be done by the next trial, but from my experience, it often isn't. And then the solicitors tell the judge will tell them off a little bit, and the case will be adjourned. It can be weeks, can be months. Personally, I've been asked to do a fitness to plead assessment with literally only a couple of days before a court case, which is almost impossible because it takes sometimes even a couple of weeks to organise a prison legal visit. And it has made me wonder, why did the solicitors leave it so late? Because they've had months since the prisoner's been arrested. And I don't really know the answer to that. I think some solicitors are very disorganised. And if I'm being brutally honest, from my experience, some solicitors don't pay their experts or pay them extremely late, months or years later. So they struggle, they have a bad reputation, they struggle to find experts that want to do the work. So following Sarah's death, a few changes were made in the system. There's more forms that we have to fill in from the prison that prove that the request for a fitness to plead assessment has been made, who's responsible for that, and there has to be a specific timescale. So Sarah Reed's death was a big deal within the world of forensic psychiatry at the time. I remember it sending shockwaves, especially because I was working in a female prison. Me and my team were very aware of what was happening. Very sad case. Okay, so I hope you enjoyed today's episode. In my next episode, I'm going to discuss the pros versus the cons of working as a prison psychiatrist. I'm going to tell you about a real life case of somebody that I've personally assessed, an extremely severe self-harmer who is called Ms. P, and I'll tell you about how we treated her, how we supported her. Before you go, please subscribe to our channel on YouTube. Not only does it help me out immeasurably, but it burns about 500 calories. Very interested to hear your experiences. If any of you have been to prison or ever visited prison, let me know. Tell me if you've struggled with accessing help for mental health issues. Tell me your insights on how you think we can improve this problem. Let me know in the comments section below. You can hit me up on the usual social media channels, including Facebook, Instagram, #PsychSaw. If you're hitting me up on Twitter, tell your favourite people about Psych for Sore Minds. They deserve it. Spread the love. Before I go, if you're a regular viewer, you will know what I'm about to say. I am going to be a speaker at CrimeCon UK. So this has been delayed until September. It's in London, I think on the 25th and 26th of September. It's a massive true crime convention, huge in the States, coming over to the UK for the first time. You will hear about serial killers, unsolved crimes. You'll hear from criminologists, law enforcement agency, and your favourite podcasters. As well as filming a podcast there, I'm going to be doing a talk about 2 real-life cases I've assessed of people who've killed their own family members. One was mentally ill, went to hospital, rehabilitated. The other wasn't, stayed in prison. If you are a true crime enthusiast, you cannot miss out on this event. Cop your tickets in the link below. Use the code PSYCH for 10% off because I've got your back. Until next time, stay euthymic, and whatever happens, do not forget, I love you.